There we go. Hi, everyone. Welcome to another Wednesday VMR. So excited to be here and so excited to be able to discuss with the amazing Kushal. Thank you so much for co-discussing with me, Kushal, while she's on nights. So she is another level boss.
It's okay. It's just going to be an excuse for the night if I didn't do good.
You always do well, and nobody keeps scores here. So we're so excited, Robbie. Thank you so much for presenting a case, and big shout out to Jillian for scribing and for Hans for doing teaching points. So whenever we can get the board up, Robbie, I'm so excited to learn from you.
Absolutely. Very excited to hear you discuss this case. You always do a remarkable job, and also the people that co-discuss with you. So today's case is a 18-year-old female who presented to the hospital. So initially, she was having withdrawal-like symptoms due to not taking methadone or having access to methadone for several days. So when she arrived on admission, she had all the general complaints of withdrawal. Also was injecting into her legs, so she had some ulcerations of the skin of the legs over the last 8 days, and there was some sloughing of the skin due to necrosis. However, the complaint changes on admission day 2 while she was being treated for withdrawal. She had 2 episodes of hematemesis and more than 2 melanotic bowel movements. And I'll stop there for discussion.
Wow, such an interesting first aliquot, Ravi. So when a person is not taking methadone for a couple of days and they are having withdrawal, that's kind of expected. But the concerns which I do have is why wasn't she taking the methadone? And usually people who are on methadone, they don't really skip it because they do know they become very tired and lethargic if they didn't take that dose. So that's the first concern I have. But then from the rest of the history of having ulcers in the foot, and I'm also concerned was that there was that discharge, was she having fever? And I would want to know more from her about that, maybe when she's a little bit more sane. Um, and if she's also using the drugs, then I would want to know if she was, another reason why they skip the methadone is that they start doing the drugs. So I would want to know if she actually started doing the drugs again, if there wasn't, if that was the reason why she didn't go to take her methadone. The next one is that when you want to restart, you would always have to, you couldn't always give them at the full dose which they are on. We would rather have to start it at a much lower level and slowly increase it. So if it's just 2 days, we still haven't reached what she usually takes. And a person with a GI bleed is what I'm concerned about if she's having hematemesis and melena. And when usually when they are having both, there is brisk bleeding which is happening. So there's a chance when a person is having a cocaine abuse, I think that could be also a reason why they can have mesenteric ischemia. And if she's not eaten anything at all, I would be wondering, I would want to know what's the cause of a GI bleed. It's if it's a gastric ulcer, or it could be mesenteric ischemia, or it can be sloughing, or if that there was an underlying Crohn's or ileitis, which we have missed because she's still 18 years old and she's in, so those were that could be the first and the manifestation of the condition itself. So that's something which I would want to know, and or would be worried about what I'm thinking about. And Sharmin, what are your thoughts?
Oh, Kushal, I totally agree with you, and I love where you start about like, oh, what happened that this patient stopped taking the methadone? Was it an access issue? Was it like going back to substance? And I feel like methadone oftentimes, we use for substance use disorder, opiate use disorder, or chronic pain, and When we're using with substance use disorder, the challenging with methadone is that it needs to go picked up every day. So it's really oftentimes becomes an access issue for a lot of patients, and seems like and substance use disorder is a very challenging disease, and um, especially being this young, she's just 18 years old. So this is quite hard. And with like a IV drug use in general, which sounds like she's struggling with, I would be curious to see like what is she injecting, and also like how she is injecting, and how she's using the needles. So just to kind of think about like the practices that she already has, like it seems like an ulcer where she injects. So oftentimes with injection drug use, we have to kind of worry about like them being negative of infections or a higher risk of like endocarditis. All those things. So keeping those complications in mind when we meet someone with that, and any chance we can get to get a better understanding, and connect them with more like addiction services would be really great, and see if there's any other ways of supporting her as she's in the hospital and she's ready to discharge. That might be easier for her. A lot of like patients that I take care of, going to the methadone clinic daily is a challenge. So if she, depending the type of substance use disorder she has, you might have some other options to go with. So keeping that in mind. And it sounds like, she first came in with a kind of withdrawal symptoms, whether it's like from the methadone or the substance that she was using. And now we have a new complaint, which is concern, as you mentioned, like melena and hematochezia. Oftentimes with melena, we map it to an upper GI system, as you were saying, Kushal. Um, I think whenever I see that complaint, the one thing is like you want to make sure the stability of the patient. So is this patient clinically stable? So if you get called, just making sure to get a set of vital signs, patient is not altered, have good blood pressure. A lot of the times when you repeat that hemoglobin right there, sometimes it takes a while for hemoglobin to accumulate. So it might not be like the most accurate presentation when you get a stat hemoglobin. So I would like always trend it an hour or like a 2 or 3 hours later to see how much blood loss that they're having. Oftentimes with upper GI bleed, kind of like the things that we worry most about is like, oh, am I dealing with a variceal bleed? She's 18 years old. We haven't heard about like stigmata of cirrhosis. We haven't heard about like any alcohol use disorders. So that is like one thing to note, because in those situations, oftentimes it's more emergent to get our GI colleagues on board, and patient tends to become more unstable because it's like a more rapid bleed. The other things that you mentioned, as you mentioned, like the most common causes are often like peptic ulcer disease, H. pylori, alcohol. And also like the one thing that I was like, oh, is there a way for me to connect her like substance use disorder to upper GI bleed? Not really. So I would just track both of them. The one thing that often happens if people have a lot of nausea, they're retching, bleeding, you can get Mallory Weisters that oftentimes can present as upper GI bleed. So my heart goes out to this patient. She's 18. Upper GI bleeds are no fun. So the things that I would do clinically, get a vital signs, get us a repeat labs, make sure this patient is type and screen. You want to make sure you have good access. You always want to get large bore IVs in case you need to transfuse this patient. Oftentimes we start IV PPIs with the patient NPO and think about like, when this patient should get an EGD. I no longer do like kind of the gastric level. She's like bringing up hematemesis. So she's, for all of the, for all intents and purposes, is having an upper GI bleed. So I think like making sure the patient's clinically stable is like number one and number two. Any other thoughts, Kushal?
Was an amazing summary of the GI bleed and current situation which we are facing in regards to this patient. So just few other things which I would want to also add on or was thinking of is that what else could be the cause of GI bleed if it's from the esophagus, if it's like a Mallory V star would be more brisk and and it's like more, if it's like a melena is also there, then I'm just thinking if she's having AVMs or Dufloy, or to just get a little bit more fancier, how is her liver function doing? And then if it's got to do something with that, or if it's like iotoenteric fistula, and to just uh, go from the most recent CPS, which we had with Cabot and Dr. Gurpreet Dhaliwal, did she swallow something and did that make a fistula? So I'm just thinking about all those things.
I know that was an incredible CPC. Everyone should go read it. I was floored. No, absolutely, Kushal. Oftentimes, the last thing I would say, by the time we see melanic stools, blood takes a while to get through the GI tract. So, you're already seeing melena. It's most likely it's a process that has happened not immediately. That is more like perhaps a day or so. But again, like I don't know if I have any data to back that up, other than a blood takes a while to get to. So most likely there was perhaps something else that is now, there was something there that is now kind of like more blossoming, and she's having more hematemesis. All right, back to you, Ravi.
Absolutely wonderful. Lots of IQ there, but I appreciate the EQ as well, due to the concern with the young patient and the situation she's in. And so let's move to a bit more data: past medical history, high blood pressure, bipolar disorder, and social history. She injects substances into her legs, namely heroin, cocaine, also crack use, no travel history, no allergies. In the exam, blood pressure 133/79, heart rate 129, respiratory rate 10, temperature 37.5, oxygen 98% on 2 liters nasal cannula. In general, she's drowsy appearing, lethargic, stains of dry blood on gown, HEANT, dry mucosa, and everything else normal. She is drowsy neuro-wise and pale skin. And I'll stop there for discussion.
Did you want to take this aliquot, Sharmi?
I'll go for it, friend. What are your thoughts, Kushal?
Oh, okay. So the things which I am thinking of is hypertension at 18 years old. That's pretty young to have it. And if it's like secondary or primary is what I'm concerned about. And if there's underlying, I'm just trying to think about that. And it's at least it's in my back of my mind. And she's tachycardic, at least that's a good thing. When she's losing blood and she's tachycardic, at least she's responding the way her body is supposed to be responding. So she's not like in acute shock, or yeah. So, and her BP is also 133/79, which is good for her. Yeah, so when she's drowsy appearing and lethargic, it could be because of the withdrawal, or it could not necessarily only because of her hematemesis or melena. And the drugs which she is using, which we know so far, like heroin, cocaine, and crack, and Karim, right? Isn't that the one which is like, I think is known to cause cirrhosis and does a lot of damage to the kidney? So, and then we do know about cocaine that it can present with either flash pulmonary edema that can cause hypertension because of a vasospasticity, and it can cause acute mesenteric ischemia when it's the superior mesenteric artery which is being constricted because of that. And the heroin, it's like, yeah, I mean, it does a lot of different things. And when they are injecting, the other thing which we would want to be concerned about, if it is laced with other like illicit drugs. That's something which we need to, like, what's the one which causes ulcers in the feet and it keeps spreading up? Zenal, no, I forget the name. So what's I can't like get the term name of the drug where they lace it into the when the injecting form, where it forms ulceration in the feet and it keeps spreading up. So that's something which I would want to make sure I'm ruling out, and there's just no way to actually find the drug. It's when you screen it, so it's going to be something which you need to be doubting or looking for. So those are the things which are going on my mind at the moment. And yeah, so I would also want to include the ICU team at this time. And yeah, Sharmeen, what are your thoughts?
Uh,
And anyone else? Yeah.
Yeah, no, Kushal, I totally agree with you. I got a couple of things that, oh, sorry, I don't know what happened to my video. Uh, oh, well, it's having a life of its own. But yeah, I totally agree with you. I think starting with like the past medical history of like hypertension and bipolar disorder. And as you mentioned, like the hypertension is someone who is substance use disorder and cocaine. Like cocaine oftentimes cause hypertension to begin with. So your thought of like, oh, maybe this is just secondary to substance use disorder, I think is very valid. And and she carries a diagnosis of bipolar disorder, and unfortunately, there is a big overlap between like kind of like mental health and substance use. So again, like I think something that a track, and as she's getting better, keeping that in mind to make sure that I don't hear anything about her being manic or anything that would suggest that we need to something that we need to actively manage, but something that again to help connect her with supports in the future. In terms of her injection and drug use, when people mix and match drugs, it makes me really, really nervous because kind of the risk of overdose becomes higher. And as you mentioned, like you narrowed on the cocaine itself, and especially like crack cocaine. Um, no, cocaine is terrible for the human body. And one thing that I noticed is that she's on 2-liter nasal cannula. I don't know if she was like placed on that for just like comfort as she's like having this hematemesis, or she actually has 2-liter oxygen requirement. Oftentimes, like with cocaine itself, it can have a respiratory, especially crack cocaine respiratory manifestation. It can have acute toxicity where you can see where you can see like kind of like patchy opacity. So like making sure we get a chest X-ray, as you mentioned, pulmonary edema in a setting of like acute hypertension is another manifestation um, of cocaine. And you really a great job thinking about the IVDU, and it's often laced with levamisole that can cause vasculitides. So that is another thing to ask how she injects. As well. So I think at this point, thankfully, like her blood pressure is stable. She's tachycardic, and as Robbie has taught us, we do not like sinus tachycardia. So making sure that we get the labs. I think like if you're worried, you can always give some IV fluid up front. She's hemodynamically stable enough at this moment that I might hold off on it for now and get the labs and give her actual blood as needed because that's why she's lacking intravascularly. However, I think that kind of like depends on the trajectory. And I always like say in these patients, it doesn't seem like she's actively bleeding, but low threshold to get more help in the form of like rapid if she starts opening up again. That is always like when you're in the hospital, it's in your back pocket. It's like when in doubt, get more help. In terms of like and the one thing that I just like note that she's doesn't seem like she has any abdominal exam. You brought up the good point of like mesenteric ischemia. An 18-year-old it's like having ischemia to the gut. Sometimes like people have ischemic colitis. It's pretty rare. Oftentimes like they have young people have good vasculature. The one thing though, when you add cocaine to this mix, anything is off the table. As you know, the vasospasms in the heart, it can cause vasoconstriction in the gut and cause ischemic guts too. Oftentimes, I would expect more abdominal pain. So I'm a little bit reassured, but you can always like get a lactate, do serial abdominal exam to make sure. So yeah, I'm like curious to know how much the substance use is playing a role or is a bystander at this point. Anything else that comes to your mind, Kushal?
Yeah, just one more thing. Because she's in the reproductive age group, I wouldn't want to rule out any pregnancy. I would want to rule out pregnancy and complications of the pregnancy itself. And that's something like HELLP syndrome or, like any thrombosis or, yeah, so all that would be another opening up another bag of worms. So I would want to get her pregnancy test or make sure that it's negative. Yeah.
Ah, so true. Beautifully said. Yeah, for sure. Like young people, productive age, when they come to the AD, always get the pregnancy test, especially because um, even if what you're seeing is not might be related to a pregnancy, you're going to be limited what medications you're going to be able to use in someone who is pregnant. So absolutely, like getting that upfront is such a great call. Thank you. All right, Robbie, back to you.
Wonderful discussion so far. You guys have discussed the textbook of GI bleed, so and the management. Very educational. So moving on to the labs, this for the CBC, Y count 24, hemoglobin 6.1, platelets were normal, chemistry, sodium 147, BUN 173, creatinine 3.44, albumin 2.7, ALP 2.7, yep. ALP 137, AST 87, and ALP, no, sorry, ALT 54, and normal bilirubin. Urine tox, positive for cocaine, opioids, methadone, xylazine, and buprenorphine. And I'll stop there for discussion.
All right, we got so much more information to chew on. Kushal, what is jumping up to you?
Yeah, a lot of things, and it's very interesting labs to work with. First of all, the hemoglobin is 6.1, so I would want to actually make sure that we are able to replenish that for her. And while we are looking at that, because like Gaulian says, whatever is lost is what has to be replaced for actually dealing with the shock. And whenever a person is when you're dealing to make sure that the person doesn't have an compromise, they don't, so if they lose stools and just regular one, the best fluid to replace with would be ringolactate. And if they are, like, so different things. So now she's losing blood. So it's how much of a fluid we give is not going to be enough till we give the blood. So we would want to make sure that's taken care of. The other, I'm so sorry, I just mute myself. So the BUN creatinine, and BUN is like skyrocketing of 173, and creatinine is 3.44. So I would want to compare it with her baseline and see how much that is. And a person who is bleeding into their gut, there is a chance for the hemoglobin to be broken down and be reabsorbed, and that can increase the BUN. So that can also be happening for her while she's having a pre-renal or intrarenal. So we would want to make sure, get the FENA and see if it's a BUN, just intrarenal or prerenal cause. Because of so many of her drugs she's been abusing, and some of them are known to cause kidney damage. And she's also having hypertension for such a young age, and that is also a risk factor for damaging the kidneys. So yeah, to also like weave it with her presentation of skin ulcers. So I would also be concerned. I mean, I do know she didn't really have a high temperature, but I would want to make sure she's not having sepsis underlying one. And that's, if her ulcers were infected, and I do know she was there in the hospital for 2 days. So I presume that prophylactically some antibiotics she would have got. So that's fine. That would be a good place to be at. And yeah, these are the things which are really going on in my mind.
Oh, um, beautiful, Kushal. I totally agree with you. I think like that hemoglobin of 6.1. And I think like the nice thing is like she's been here for a few days, so hopefully you have like a prior hemoglobin, so you can figure out like what the actual drop is and how worried you need to be. But if someone on her, like giving her a unit up front. I'm gonna track that leukocytosis. Oftentimes people with like GI bleeds, you can have like a stress response. However, in the setting of her injection drug use, she has high risk of infection, and especially bloodstream. So making sure we get that blood cultures to make sure we're not dealing with, endocarditis would be prudent. And if she has like a little bit of a mild LSD abnormality, I don't know if she's priorly has had any right upper quadrant ultrasound. Oftentimes in the setting of GI blindness cirrhosis, you want, as I mentioned, you want to give ceftriaxone prophylactically. Though I don't, I would 18-year-old is like quite young unless like she has like a genetic condition for her to have cirrhosis. So but something to keep in mind. What is like jumping out to me is like her electrolytes, and especially that creatinine has me worried. And someone who is, and you're right that BUN of 173 makes us think that with the some of that is like due to her upper GI bleed that we're seeing, but that creatinine has me worried. I think one thing we can for sure, but she has a little bit of a hypernatremia, and hypernatremia is always a free water deficit. So you always are fluid, like free water down when you have a little bit of a hypernatremia. So that tells me like she's under resuscitated and she needs more fluids. And so the question becomes like how much of this is a pre-renal pathology and it's just the effects of the hemodynamics, and how much might be a contribution from an intrarenal process. I think in someone like her, I would just make sure I would get all the studies. She's a high risk of ATN because of her cocaine use. We kind of mentioned the love muscle and small vessel vascularities that can cause in those contexts that she's using that. So I think I would like make sure to get a UA and trend that creatinine really closely to see where it lands. But she's definitely, as you mentioned, is at like high risk. The question is like, is it all due to this like hemodynamics effect of the upper GI bleed? It just like a pre-renal AKI, it improves, or if it's like stays elevated, or if it like continues to get worse, then I would become more worried about it and entertain like ATN or like glomerulonephritis if you need to go down that path as well. So yeah, like and I think as we worried about like polysubstance use and the UTOX being positive for multiple drugs, the one thing I think you want I was like thinking Levamisole, but I think you were thinking xylazine. Do you want to talk about it, Kushal?
About xylazine,
Mm-hmm.
it's kind of like a very interesting drug, especially when you see it in clinically, because first of all, you need to have a high suspicious for thinking of it. The other one is that it's more commonly causes it's more common in laced for drugs for IV drug use, and it causes ulcers which ascends from distal to the proximal, and they are necrotic and they are sloughing the way Ravi had described. So and they spread, and we don't really have an antidote for that, is what I understand. And they were actually used as anesthetic agents for dogs or animal in vet. And now they are lacing it with IV drug use. That's about it. That's all I know.
No, that was textbook. That was perfect. Yeah, no, that is my understanding. In my patient population, I don't see this, but I think it's more common in East Coast, if I'm not mistaken. But yeah, like that's how I know. I think there's like you can also have like acute toxicity, and then the chronic manifestation tends to be like this. Skin ulcerations, and a lot of like I believe is like kind of similar to opioids, that is like depressant. Correct me if I'm wrong. So yeah, oh boy, lots to take care for this patient. All right, Robbie, back to you.
Absolutely wonderful. I'm so glad you're able to discuss so much from this case. I'm just sitting back and just enjoying what you have to say about this. So I think you've described what should we do and all the anticipated problems here. So I just want to say that the kidney baseline kidney function was normal, and she was transfused, and the kidney function returned to normal. So a lot of it was the hemodynamic issue and the anemia. And the next course of action was doing a gastrointestinal study. So EGD was necessary, colonoscopy as well. Now share some pictures here. All right, so you can see this picture. So eventually she ended up in the ICU, and she had another drop in the hemoglobin and was having bright red um, bright red blood per rectum. CTGI bleed was done, which was negative, and they saw large ulcers with some high risk, with no high risk stigmata. And she was bleeding from there. And then looking at her esophagus, I'll let you look at this. So this is sort of midway down the esophagus. Any comment about this?
That just looks very worrisome. And yeah, I'm very, I mean, looks really bad. And it just feels like she was at the right time in the hospital. Um, yeah, someone could help her out. So yeah, bless her soul. So that's, yeah. And then I'm just seeing ulcers in her, the first two photos which you did show. And the second one, like I do have I mean, there is a good chat comment over here saying that they would be concerned about fungal infection. Yeah, that's, I mean, given her immunocompromised state, we can't really rule that out. I'm not able to really make out if it's the base of ulcer or just a clot which is sitting there in the picture A. And there was a brisk blood coming out from her rectal. And was this after her procedure or was not connected with it?
Or before the procedure?
Oh, okay. So the one other thing which when we are seeing a brisk blood is that we want to rule out if it is AVM or if it is due to Dulafy, and the other one would be just an ulcer which is there, which is bleeding. And we would want to stop the bleed from progressing. And different ways of doing would be either cauterization or embolization, where IR can do the embolization. So these would be the things which I would be concerned about. I'm not quite sure if I would want to go and biopsy this. Yeah, I'm just not too sure that I would want to do that. What do you think, Sharmin?
Oh, yeah, this is a scary picture. I totally agree. And I think like a fungal is a great thought. My initial thought, it was like kind of like a black esophagus, like acute esophageal necrosis. Um, I think it's like more circumferential. I don't know exactly, to be honest, how it would look, but like kind of the black, kind of the linear that is like worse. I don't know if that's the junction we're looking at, but I believe that is like kind of the most where you would see it kind of spread from. So that is like if you show me this and I'm like clinically taking care of a patient without the help of any GI colleagues, that's what I would be most worried about, because that is like kind of the most morbid, and oftentimes is because it's like this diffuse circumferential black discoloration, and it's kind of like that represents necrosis of the mucosa, and oftentimes it's because of like systemic it's like a double hit model, right? Like you have a systemic hypoperfusion to the esophagus, and then oftentimes then you have another direct injury or something else that happens that causes necrosis. And like we often see it in like severe shock, but I wonder like with her maybe substance use, and like especially with like cocaine that causes vasoconstriction, maybe that was like kind of the second hit model, that second hit reason why she had it. um yeah, other things that like any like systemic diseases, and I would personally put like kind of like malnutrition, substance use disorder in that category. You're like a little bit of a higher risk of it. So that is something that it would be kind of like my no miss diagnosis. And oftentimes like management is just conservative and treating any underlying cause. But that would be like kind of my first thought. In terms of like the biopsy, I would be a little bit nervous, especially if I'm worried about that might be a necrotic mucosa, that it could be potentially at risk of perforation. But a great question to ask GI colleagues. Ravi, I'm on the edge of my seat. You just
Very good contemplating over this picture. I just gave you this picture and you were able to squeeze so much knowledge out of it, but you're absolutely correct. So the EGD read was, so the initial picture I showed, there was two ulcers in the stomach. So the bleeding was from there. But to everybody's sort of shock when this was presented to me, the CGD finding, you're right, the circumferential black discoloration and ulcerations in the entire, so it was the entire length of the esophagus. And this is consistent with necrotizing esophagitis. So what this was thought to be due to, like you mentioned, the hypoperfusion, direct toxic effect, and so on. There's so many causes. Some of the chat is talking about bulimia, repeated vomiting. So this was apparently thought to be due to cocaine. And if you take what Kushal had mentioned, mesenteric ischemia, this is like mesenteric ischemia of the esophagus. So she was in the stomach, but this is now the esophagus. So I've never seen anything like this. And it's reported to be quite rare. So the outcome of the case, she actually did pretty well. So usually you allow for healing. You remove the inciting agent, and she would need protonics as well, because you will possibly some reflux as well, causing caustic injury on this. And patient actually had resolution of the bleeding. This these ulcers were addressed by GI, and she was then discharged successfully without any more bleeding with an appropriate hemoglobin. Any comments in the case before I just kind of say 2 minutes about this condition?
Wow, I'm just so glad she did good. And then I do know that black esophagus, that's what it's called as, is like it's pretty deadly when it comes for bleeding. And so probably that's what really happened, and not really the ulcer which was causing it, or probably just both of it. Yeah.
Oh my gosh, I've never seen anything like this from cocaine, Ravi. This is wow. Um, yeah, a great job discussing, Kushal. That was brilliant. And yeah, it just I think it strikes me that I think if we would see kind of like this necrotizing esophagitis or AEN in someone like older with more medical comorbidity, it is a very high morbidity and mortality disease. And I think like the fact that she's young and 18 really, really is working for her. And I think at age 18, when you're developing upper GI bleed, a black esophagus, like I worry so much about this patient and the trajectory that she's on. And I think getting her through this and as much as possible trying to help her with this chronic disease that she has in substance use disorder. It's perhaps the best thing we can do for her. I worry about her future. She's 18 and had to go to the ICU for a massive upper GI bleed and that esophageal necrosis. Like, this is incredibly sad. And I'm so glad you were able to get through it thanks to the incredible care you all provided. Ravi, would love to learn more from you.
Sure, absolutely wonderful discussion, especially something what it was kind of unexpected, so it's nice to learn this. But the treatment is exactly what you had all mentioned about upper GI bleed. What's interesting, the cocaine. Do you notice the blood pressure was inflated because of the cocaine as well? We see really high blood pressure. So she had a very good blood pressure, and we're like, oh, okay, she's hemodynamically stable, but it's actually inflated by the cocaine. So this is pretty rare, and you tend to see, I didn't have the whole picture, but you tend to see a sharp demarcation of the GE junction. And histologically, like you talked about Kuchal doing a biopsy, but under the microscope, if you did a biopsy, you would see mucosal necrosis, disruption of muscle fibers, and no infection usually causing this. But when you have disruption of muscle fibers too, you can tend to have perforation develop as well, which can be devastating. The mortality rate is about 38%. And you may see this like 0.2% of the time, so very rare with cocaine use. And in the literature, is probably only, I can count on one hand how many cases probably there are. And the cause of this is the pathomechanism which both of you described, like vasoconstriction and ischemia necrosis causing ventral esophageal tissue necrosis. If you have coexisting reflux, that can actually add fuel to the fire, and it can make it more the lining more vulnerable, and it can potentiate bleeding as well, and vomiting as well. So cocaine can also cause severe vomiting, and that can also make it worse and can cause Mallory Weiss, like you'd mentioned, Sharmin. So yeah, this is a case of upper GI bleed, and you rarely see that, right, with melena as well. And did you see how high that BU? The BU was really high, right? It was, I've never seen a BUN that high before, but there was a massive amount of blood being expelled from the upper GI tract. Thank you.
Ah, amazing, Ravi. I always learn so much for you. Thank you for bringing so much education and so much teaching to VMR. Like, VMR would not be the same without you. So thank you so much for being such an incredible member of this community. And I learned so much, and it was like such a great case to think through. And yeah, you're right with like the blood pressure being inflated because of the vasoconstriction. And I think like, yeah, now that I'm like kind of reflecting that, hypernatremia even becomes more impressive. That is like, wow, she is really, really volume down. So yeah, fascinating. So much to reflect on. Kushal, amazing job. Thank you so much for discussing well-being on nights. It was such a pleasure. All right. Thank you so much, Jillian, for scribing, and Hans, to you for teaching points.
Yes, first of all, thank you for this interesting case, because this is what we see so often in, at least where I was in Bakersfield at Kern Medical. We had a 18-year-old patient who came to the ED for bleeding. She had a gastrointestinal bleed. At first, we make sure the patient is hemodynamically stable. If this is of no concern, then we can think of what she was going through, methadone withdrawal. And there we mentioned that patients can be lethargic. They can also present with lacrimation, rhinorrhea. They are oftentimes in pain, and they have something what we call an autonomic hyperactivity. Secondly, her main concern was hematemesis and melena in the stool. So we had a GI bleed, and it was most likely located in the stomach, as she had fresh blood that she was vomiting, and she had digested blood in her stool. So the first thought was a gastric ulcer. It can either be from H. pylori, it can be from alcohol abuse, it can be an arterial venous malformation, it can be a fistula or a connection between the splenic artery and the stomach, where the ulcer corroded into outside area. Then we have the other possibility, which is an esophageal tear. The management for GI bleeds would be to give fluids, make sure the patient is stable, which is the case here. We do a blood match and think about a transfusion, and then we continue with PPIs and maybe even octreotide, which dilates the splenic vessels and thereby reduces the bleeding. Ulcers at the injection site is what we notice, and these could either be from drug abuse itself, that is, the drug can cause ulcers, the trauma that we incur by injecting, and then infection. And there is a big problem of developing endocarditis secondary to as aureus and other microbes getting into the bloodstream. Her kidney function was reduced. She had a CR of 3.44, and that could either be from cocaine abuse. It can also be a pre-renal hypovolemia, and that was corrected during her stay in the hospital. The hypovolemia could also be secondary to bleeding. We mentioned xylazine, which is an anesthetic in animals, which can be abused as well, and this can cause hypotension. Then in turn, again, it can affect the kidneys. So does cocaine through constriction of blood vessels. We also noticed that her blood pressure was artificially normal. It was 133/80, which is normal, but that is most likely because of cocaine abuse. And EGD subsequently not only showed a gastric ulcer, but also necrosis of the esophagus. And in her particular case, this is caused by cocaine hyperperfusion. Other possibilities for necrosis of the esophagus, which I haven't seen so far, is severe stress, trauma. Diabetic ketoacidosis can also cause it. Caustic injury if somebody accidentally ingests sodium hydroxide, and it can be post-radiation. So thank you very much for this very educative bread and butter case.
Amazing teaching points. Thank you so much, Hans. I'm always so impressed with how you all put these teaching points together on the spot. Thanks all. Have a good rest of your day, and we'll see you tomorrow. Thanks again, everyone. Bye.